So Alexandra Schmidt is the next speaker from University of Sussex. So Alexandra, I'm trying to locate you in the wall of faces. Oh, there you are. Hello. Would you like to put up your slides?
Yeah.
Is your supervisor here, Daria Gazina?
Yes.
Hi, everyone. Yeah. Can you hear me all right?
Yes, we can see you.
It's welcome. Good morning, everyone. So thanks very much for organizing this conference. I remember last year it was a great success, so hopefully it goes very well this year as well. So today it's my great pleasure to introduce Alexandra or Ali Schmidt. So Ali is working on her PhD project at the University of Sussex under my supervision, as well as under supervision of two clinical psychologists, colleagues at Dr. Clara Strauss and Dr. Nick Gray. And so Ali is in her third year, and during the past year, so she's been working on setting up a new study using the data or collecting the new data at the APT services, improving access to psychological therapy services. And today, Ali is going to present a progress report on this study.
Thank you. Great.
Okay.
Thanks, Ali.
Right. So hello, everyone. So my name's Ali. As Daya mentioned, I'm in my third year of my PhD at the University of Sussex. And today I'm talking to you about the study that I'm planning to run in the NHS Talking Therapy Services, IAP, to look at predictors of psychological treatment outcomes for older adults. So just to give some context here, older adults are defined as anyone as 65 or over, but of course I appreciate this long period of life still after that time, but this is for purpose of definition, this is the definition of older adults in this study. Okay, to give some background, so common mental health problems like depression and anxiety are highly prevalent in older adults, with around 20% of the older adults suffering from one of these conditions at a time. This is exacerbated by the pandemic and also recent reports that there seems to be some concern around the ability of older adults to bounce back from the effects from the pandemic. So therefore it's a really important topic right now. Psychological treatment is successful, but the evidence for older adults is mixed, and overall the recovery rate is around 50%, so there is some room for improvement. To identify factors that can predict treatment outcome could allow for adapting existing treatments or develop completely new treatments for people where existing treatments might not work. So we've carried out a systematic review of existing literature and identified 28 treatment outcome predictors, for which I've recently submitted the manuscript. To give a bit of background on this review, so there's some highlights. So one of the most consistent predictor of positive treatment outcomes was homework completion. So homework, not in the traditional sense. This is more like mutually agreed tasks that the patient will carry out between sessions. So when these were complied with or completed, this consistently predicted better treatment outcomes. Baseline symptom severity was extensively studied across a lot of conditions and treatments, but there were some contradictory findings, with some studies finding higher symptom severity predicting worse treatment outcomes, and other studies finding higher symptom severity predicting better treatment outcomes. So there is some inconsistency there. And lastly, there were some factors that never predicted treatment outcomes, such as gender, income, or physical conditions. Across the 36 studies that were included in the review, there was a high variability in findings, a lot of mixed and inconsistent findings. And overall, the research appeared to be quite exploratory at this point, with 40% of factors having only been reviewed by one study and therefore requiring replication. Overall, there was a lot of studies with very small sample sizes. So more than 2/3 of studies had fewer than 100 participants, which could mean that some factors could actually not be identified because the studies were underpowered to find any effects. And lastly, there seems to be a high focus on CBT as a treatment type and depression and generalized anxiety disorders, and very few studies looking at other types of treatments or other conditions such as PTSD or obsessive compulsive disorder. So with all these limitations in mind of the existing research, what we want to do with this study is look at what are the predictors of psychological treatment outcomes in the IAPT services. And secondly, whether these factors affect treatment outcomes differently for older and working age adults. So in terms of participants, we're looking to recruit 700 participants, ideally split evenly between working age and older adults. The inclusion criteria, therefore, is quite broad. So we're looking for people aged 18 and above that have been offered treatment in the IAPT service in step 2 or step 3. So step 2 is more for lower intensity therapy, and step 3 more higher intensity, such as CBT. This slide is to show how the participant journey will look like when they take part in our research. So the process starts with an initial assessment in the IAPT service, where when they then get accepted into the service, they will be invited to take part in our study. So this is whilst they're awaiting the actual start of their treatment. So we will ask them to complete a baseline questionnaire. And once they have done that, they will just continue awaiting the start of their treatment, then go through their treatment. And then post-treatment, we will ask the IAPT services to provide us with post-treatment data, such as symptom severity before and after treatment, what type of treatment the patient received, and how long for. The possible treatment outcome predictors that we're looking at, they have been informed by the systematic review that we've been through and are across a number of domains. Psychosocial, looking at people's experience of life events and associated coping style. Clinical aspects such as the symptom severity at baseline, or whether they have any concurrent medical conditions. Treatment related, so what type of treatment they received and how long for. Socio-demographic information such as their education. And then also some factors that have not previously been studied as predictors, but have been associated with mental health outcomes. So we want to see whether these factors, some of which are also modifiable, may be also predictive of treatment outcomes, such as self-compassion, resilience, or loneliness. The outcome measures we're looking for, they're routinely collected in the IAPT services and are relating to the symptom severity of the specific condition that the patient is experiencing. So, for example, the patient health questionnaire or the generalized anxiety disorder assessment or any other anxiety disorder specific measures. the primary outcome is recovery as per the IAP definition. So in IAP, people are assessed in terms of whether they are at caseness, which means that whether their symptoms are severe enough to be considered a clinical case, and whether they then have recovered after treatment from this stasis is the primary outcome. As a secondary outcome, we're also looking at a continuous measure of change in symptom severity, which would also be interesting, especially for the people that have just gone above the threshold, maybe to reach caseness, but might not have improved that much overall. So that's why we're looking at the secondary measure. In terms of the analytical procedure, so initially we'll be looking at calculating recovery status for each of the participants, and then looking at the association of treatment outcome of individual predictors. And for any predictors at this point that were significant or seem to have a significant effect, they would then be put into a larger model where we're looking at multiple factors simultaneously to see if in the presence of other factors, these factors are still important. And then we'll be looking at assessing whether the factors affect the outcomes differentially for the different age groups. And then lastly, or like as a second analysis, we'll also repeat these steps for the secondary outcome of change in symptom severity. So here's a brief overview of the activities to date and what is planned next. So in spring and summer last year, I created the research documentation, such as the research protocol, and patient-facing information, such as the patient information sheet, consent form, and any recruitment materials. Throughout this process and ongoing, we've worked with PPI groups who've given me actually really valuable feedback in terms of how to make the materials as patient and participant friendly as possible. And yeah, this has been really helpful to move the project forward. In October last year, I obtained the pre-sponsor and sponsorship approval of the university, which then paved the way for approaching NHS ethics committees for approval, which I obtained in January this year. And the study was also adopted into the NIHR portfolio, which has been really is great news, because this allows us now to work with IAPT services nationwide to see if we can roll out the study there. In terms of recruitment and engaging sites, so this has started from February and will be ongoing until the end of this year. So I've been working extensively with Sussex Partnership Trust to get the recruitment going, and have also been in discussions with other IAPT services to see if we can roll out the study there. So recruitment will be ongoing until the end of this year. And then in spring next year, I will be asking the IAPT services to extract the data from their systems, which will then be fed into the data analysis that I mentioned previously. And then we'll work on writing up and sharing the findings in summer next year. So this leaves me to say thank you to Mental Health Research for UK for making all of this possible in the first place, and also my supervisors, Dr. Daya Gaisina, Dr. Clara Strauss, and Dr. Nick Gray, who've been really supportive in helping me with this project.
Thanks. Thanks very much, Ali. Great. Would you like to take these slides down? That's great. If anyone has any questions, then they could put their hand up. We already have several hands up. And then, all right, Kate Bailey, you're first on my list.
Great. Oh, thank you so much. I'm really, really pleased to see this study. So I'm an old age psychiatrist, and I think we know from previous kind of work in IAPT that actually older adults do really well once they're kind of engaged with IAPT, and actually better than working age adults. But I guess one of the questions I had is about the access to IAPT in the first place, because I guess my experience of referring older adults is that if there's any sort of issues with sort of frailty, cognitive impairment, communication difficulties, that they can't kind of work with IAPT in the first place. So there's a group of people who kind of can't do things over the phone, or so I guess I just wondered, that's obviously not possible to study in this study, but if there were any thoughts about kind of how to capture sort of those people's experiences, because I think working with the CMHTs for older adults, one of the big, I suppose, subjective predictors of outcome is actually flexibility of the service in order to be able to go and see people at home and work with people who might be in and out of the acute hospitals or might have cognitive impairment. So it was just a kind of question about that. But
Yeah.
Thank you for doing this work.
Thank you very much, and thank you for the really good question, actually. I agree. I think the access to the service is something that is of my concern as well, and also with the pandemic, even thinking about access to technology to still have therapy within the services. So I think, yeah, I unfortunately, I can't really address this in my research right now, but that would definitely be something maybe post PhD that I could extend and maybe look at, you know, in further studies. But yeah, I agree. It's definitely of concern.
Are there any that I saw a sort of fleeting phantom hand earlier on, but it seems to have disappeared. I have a sort of slightly related question, which is that Kate mentioned cognitive function. Now as a member of your target population, I can tell you that cognitive function does begin to deteriorate. But actually, also comorbidity with physical disorders increases hugely in the 60s and 70s. And are you planning to look at that as an outcome, as an outcome predictor? I have no data on this, but you would predict that, say, some chronic disease might well affect outcome.
Yeah, so thank you for the question. Interestingly, so I thought this would be the case as well. From the systematic review, it appears that this was not a predictor of outcome, but as I mentioned, I think because there were quite a lot of studies that were very underpowered to find effects, that might be one of the reasons. But yes, it is something that I'll be asking about in the questionnaires, about any physical long-term conditions that the patient may suffer. So I want to look at that again, absolutely. In terms of cognitive impairment, also actually from the review, it appears that a lot of the cognitive measures did not predict outcomes. So this was actually studied quite extensively, but apart from some cognitive flexibility measures, none of them seem to predict outcome. And that was something that I had originally planned to look at as well in this study, but because of the difficulty trying to do these tests remotely, I had to drop that in the end. And that maybe is also something that once we can maybe take measures again face to face, that might be easier to do again then, but to set this up remotely seemed to be really difficult. So yeah, that's why I haven't included it in this newer study, but that's definitely something still on my radar.
Right, thanks. Any other questions? Okay, well, oh yes, one more, Claire.
Yeah, I was just, I mean, you're hoping to recruit, I think you said 700 participants, which is a big ask. But I just wondered what the proportion of people entering the IAPT service were in your kind of working age adult group and what proportion were in the older group?
So yeah, the proportion of older adults is much lower. It's between 5 and 10%. Yes, it will be harder to recruit from this age group. But I think the fact that we can hopefully work with several IAPT services will make it somewhat easier to reach the recruitment target. But yes, it will certainly be a bit challenging.
Okay, but the fact that you've got it approved on the NIHR as an NIH by the NHR should help greatly with that, I would have thought. But and it's great to see an ambitious, large study in this important area. So yeah, well done and great talk. Thank you.
Thank you.